Hello and good evening. We are observing Wound Awareness Week from August 23rd to 29th. The focus is on the awareness of chronic wounds among healthcare professionals and the general public. Wound treatment is a significant part of the total healthcare expenditure, but the use of specialized clinics, advanced technology for more rapid healing, and modern innovative approaches can drive the cost to be substantially reduced. And this is what we are going to know more about today. Today's webinar is on how specialized clinics can improve outcomes in chronic wound management and managing PAD. Today, our esteemed speaker is Dr. Sanjay Desai, Professor and Head of Department of Vascular and Endovascular Surgery at Ramaiah Medical College and Hospitals. He has been on the organizing and scientific advisory committees of many organizations and institutions, including the Rajiv Gandhi University of Health Science, Vascular Society of India, and various ethics and medical audit committees of MS Ramaiah Medical College. He is an academician and researcher par excellence, reflected in the various papers he has published and involvement in clinical trials. He has also contributed to society by starting a charitable trust for needy patients and being part of an NGO to conduct medical camps and education programs for tribal people of reserve forest. He also has a vast experience in managing venous diseases, including venous thrombosis, endovascular procedures for preventing pulmonary embolism, and managing complicated vascular malformations and carotid interventions, both open and endovascular. I welcome you, sir, today and handing over the platform to you.
Thank you, Pooja. Good evening, everyone. It's been a year since we've been doing webinars, and we have now got used to speaking to a window. But hopefully, everybody is there, and we'd like to make it interactive. Please feel free to ask questions, interact at any time. Chat boxes are open, and I think. Yes, like Pooja put the perspective, I think what we look at wound management and chronic wound management with PVD is something which is becoming very, very important. We all know that the diabetes population has increased tremendously, and we lead the world in the diabetic population. And once the diabetic population starts, we know the complications of diabetes also is going to be a consequence of it, and we are seeing more and more wounds. So that adds to the burden of wound management. And what we see is a wound as just should I say an ulcer as just a wound, or a wound as just an ulcer, is not the right way to look at it, because a wound, an ulcer, whatever the reason, it has to heal, and unless it heals, the patient is definitely immobilized or discomfort because of it. So we have to look at wound management more scientifically, more technically, and more elaborately, I would say, with the growing number of patients we see with wounds. When I say wounds, not necessarily diabetes. I take up diabetes because obviously that forms the bulk of what we are all seeing. I'm sure all of us see a lot of patients who are diabetic who have these wounds. And when it comes to managing these wounds, I think it's very, very important that we know what these wounds are about, what causes these wounds. Only then we can go about treating. So what I talk today is how specialized care centers help in management of wounds, wound care, and PVD. I will not stress much on PVD. I'll just probably just rush through PVD, but I would definitely stress on wound management and what wounds have to be, how wounds have to be looked at. And again, when I say specialized clinics, let us not get this thing of specialized in the way of managing our patients, because specialized does not necessarily always mean high-tech technology, very professional, specialized personnel to be there. It's just that we need to know how this is done and how we handle these patients. I think that's the most important thing. So to start off, I will start sharing my screen, and we can just go through it. Just let me know if my screen is there. Are my screen visible?
Yes, it's
All right.
visible.
Okay. So So this is what I'll be talking about: how specialized clinics can improve outcomes in chronic wound management and managing peripheral arterial diseases. Like I said, don't get carried away by specialized clinics. It's nothing fancy. We're just talking about probably specialized in educating ourselves in managing these wounds and probably peripheral arterial disease. So I'll start with basic wound healing. Uh, we all know what a wound is. A patient comes with a wound. All that he expects is the wound to heal, and that is all that his complaints are. He doesn't know whether the wound is caused due to diabetes, due to arterial insufficiency, due to neuropathy, due to just venous problem. He just wants the wound to heal. So when we talk about wound healing, we should understand that it's a dynamic pathway that optimally leads to restoration of tissue integrity and function. It's not good to just heal the wound and leave a raw surface or a very delicate skin covering where the patient cannot bear the weight, or if he has a wound in his hand, he's not able to hold anything. So we have to make sure that apart from restoration of the tissue integrity, we have to establish or maintain the functionality of that particular area. So it is very clear. We know through our basic sciences that it involves coagulation, inflammation, ground substance, matrix synthesis, angiogenesis, fibroplasia, epithelialization, wound contracture, and remodeling. I mean, all of us have fallen down in our childhood. We have scraped our knees, we have scraped our elbows, and we never look at it. We just bleach, you know, just to put. I don't know if you have done it as children. Just put some saliva on it, or just the paper or whatever. You grab it. Eventually, it heals in a couple of days, and you're proud of that scar, and you go around showing it. But we never look at so many factors which goes into wound healing. Every time a small wound happens, there's so many things which happens. This is important for us to know because the reparative process, if interrupted at any of the stages, can cause, not necessarily the wound will not heal, but it may not lead to good scarring, it may not lead to proper functionality, it may lead to multiple other problems. So I think it's very, very important that we understand what wound healing is. Phases: the starting phase, we know it bleeds. There is then there is hemostasis, then inflammatory phase, then proliferation and granulation and remodeling. Now, all these stages are important. The initial stage, of course, we are talking about chronic wounds. The initial stage doesn't come, but when we start seeing chronic wound, we look at it, if at all it is healing, in the proliferative and granulation phase, and then look at it in the remodeling and maturation phase. And this is where a lot of them patients come with chronic wounds, because this is where it gets stuck, and beyond this there is a problem with the wound healing, and this is where we have to try and interfere or probably intervene to get these wounds to heal. Again, causes for wound healing: there are local causes and systemic causes. Local causes can be anywhere ranging from wound infection, tissue hypoxia, repeated trauma, presence of debris, and necrotic tissue. Systemic causes, like I said, diabetes tops the chart. Then we talk about vascular insufficiency, then malnutrition, I mean, there are various causes which leads. Eventually, the systemic causes are shown in the local factors. If there's diabetes, there is angiopathy that leads to tissue hypoxia, or if there is malnutrition, there's not enough nutrition going down, that leads to proper not the wound not healing properly. So that these are always interrelated. So it's not as simple as just looking at the wound and treating it. Ischemia is what I would like to stress upon when we talk about wound healing. Ischemia does not always mean arterial. When I say arterial, a major artery obstruction, it could just be vasoconstriction, it could just be hypotension. Patient may have low cardiac output. He's not really able to put out so much pressure that the tissues are perfused, the capillary tension is not maintained, nutrition exchange does not happen. Persistent hypothermia, we know, leads to vasoconstriction. Venous congestion, when there's a lot of venous congestion, that also leads for to wound not healing when we talk about venous insufficiency. Or it could be local causes, constrictures, sutures, ligatures, etc. Now eventually all of this leads to ischemia, and ischemia leads to problems with wound healing. There are various other causes for ischemia. I think the importance is to know what it is. When we talk about ischemia, like I said, maybe I'll just finish this first few slides in peripheral arterial management. When we talk about ischemia, it doesn't necessarily mean the smaller vessels involved. It could be anywhere from the big artery to the smaller arteries. So I'll just briefly go through, if there is an arterial obstruction. You look at this iliac artery. This is the bifurcation, and there's a narrowing here, and that is leading into decreased blood flow. Now, this can be managed by a simple iliac angioplasty, and then this is the end result. You see that the narrowing here has been opened up, and then the artery is restored. So that improves the blood flow. This is same simple endovascular techniques. Now, even complicated, bilateral iliac artery diseases can be managed. You see that's the aortic bifurcation. There's narrowing of arteries on both sides with an ulcer here. So you just put two balloons from either side of the femoral artery, open it up, and this is what it looks. So compare this to this looks almost normal and with full caliber vessels, and it improves the blood flow. Now, again, we look at femoral artery. Again, you see this is lower down of the femoral artery. There are multiple narrowing segments. Again, put a balloon down there, open it up, and then, if necessary, stent it, and then you restore the blood flow. With the growing diabetes, we are seeing a lot of lesions below the knee level. We talk about smaller arteries getting affected. So whether it is diabetes or Berger's disease due to smoking, we see them affected. And with growing endovascular techniques, with growing endovascular equipment, much more refined materials available to us, and lots of work being done on it, we can even do endovascular interventions even in the arteries below the knee. What I'm stressing about now is the endovascular aspect in treating this peripheral vascular disease. So it is more or less almost all of vascular fraternity. If you ask all vascular surgeons, most of our work is now becoming minimal invasive. We talk about endovascular, just put in balloons through a small puncture through the femoral artery or the brachial artery, and then try and open these occlusions. So lot of these can be managed with simple, non risky, or probably with less risk interventions, and they're all daycare, maximum a day or two stay, and then they do pretty well with endovascular management. Again, this is just to let you know if there is occlusion at the knee level and small arteries are occluded, you just see small branches, and then you're able to open up the popliteal artery into the anterior tibial artery, and that restores blood flow beautifully down into the feet. We can go almost, I don't think I have the slides of that, but you can go up to the foot, you can go into the plantar arches, open up blocks even in the smaller arteries, and we have now materials which can open up digital arteries. You can go in and thrombolize, take care of this. So to restore blood flow, to manage peripheral vascular diseases, endovascular options is now the main line of treatment. And it is pretty simple. I just highlighted this because like I said, I will not go into details of PVD management. I'm just highlighting what probable options are there, what simple options are there, because vascular interventions is still looked at as poor result oriented intervention. So a lot of people, a lot of surgeons, a lot of diabeticians, when they see gangrene of the foot, and the first option is go for an amputation. I don't think revascularization works. But what I would like to stress is revascularization does make an impact. With growing endovascular, with growing technology, lots of specialized people, personnel trained in it, are very much capable of taking care of these arteries and trying to open it. So I just showed you right from the iliac down there. The same thing is with the upper limb. You can open up subclavian, brachial, radial arteries, etc. Fortunately, we don't see so much of wounds in the upper limb, which requires intervention as much as we see in the lower limb. So our concentration is usually on the lower limb. So I would like to stress here, when we talk about wounds, if there is arterial insufficiency, if it is correctable, I think it needs to be corrected. and it is possible to be corrected by simple endovascular methods. Doesn't necessarily have to go in for major bypasses, major surgical risk involved. So just a simple endovascular procedure does help these patients. So that was the idea of, of highlighting peripheral interventions, that vascular interventions, arterial interventions is very, very much possible. The same thing with venous insufficiency. If there is venous insufficiency, we can still take care of these veins by laser, radio frequency ablation, surgery, and take care of these venous hypertension and help the wounds heal. So vascular has made a lot of difference in managing these wounds. So I think I would stress again that wound management, unlike say 25 years ago, when there was a wound, there was an artery block, the next option was an amputation. I don't think that should be the norm present day. There is an option, there is definitely an option to try and improve the blood flow. So we shouldn't be looking at loss of limb, loss of toe, etc. We should be trying to revascularize as much as possible. Having spoken about endovascular, I think when we talk about major bypasses, revascularization, we always indicated when there is no improvement in medical management. It's not necessary that all patients have to undergo revascularization. We start with optimal medical management, see how they are improving. If they are improving, that's good enough. If they are not improving, then we probably consider intervention, whether we speak about endovascular or, of course, we talk about distal bypasses. These are, of course, bigger surgeries, major surgeries where we try to bypass the occluded vessel. So in this case, he's got a small vessel disease with just pedal vessel opening here, and you can see the vein taken and bypassed from the proximal femoral or distal popliteal, distal femoral artery into down into the pedal artery. And even these work wonderfully. We have seen bypasses which have been functioning for 20 years. More than that, it helps the patient's wound heal and give them back that quality of life which is there. Again, if you talk about major aortic arterial insufficiency, if you look at this aorta, that's the renals, and there's a total occlusion of the aorta. And this can easily be bypassed with an artificial tube and then revascularize both the lower limbs. So there are options, and these with the present day technology and anesthesia, the refinement of medical care, most of these surgeries don't carry that high risk which used to be there earlier. Most of these are done pretty much like routine surgeries, and they do phenomenally well, and they have a good patency. Most of these patients are happily following up and do well in long-term follow-up. So there are options, whether we talk about endovascular or surgery. There is definitely an option in trying to take care of these arterial insufficiencies. So I think as far as PVD is concerned, I think I will leave it at that, saying that vascular interventions correcting blood flow problem is definitely a possibility, and it can be done in most of the cases endovascular with simple angioplasty stenting, in some cases probably requiring bypasses. So now, coming to basic wound management, what exactly are we looking at? Specialized clinics and diagnosis. I think what we should understand here is the major component here is how do we diagnose. The component of specialized clinic is not necessarily a specialized center. I could be a diabetologist seeing outpatients in the clinic. I just need a little bit of specialized, space and probably people and trained in it to identify the problem. The first and foremost thing is we need to identify the problem. If we identify the problem, the rest of it falls in place. So diagnosis makes the bulk of managing any of these wound care. Know the possible problem. One is, it is said your mind, your eyes don't see what your mind doesn't know. So unless we know that there is a problem, we will not be able to diagnose it. So we need to know, we need to be aware of the problems. What are the possible causes the wounds are not healing? What are the possible causes which can be rectified? So we need to just probably train ourselves, educate ourselves to this. and then of course diagnose the problem. Unless these three are done, unless we know that this is how it is, it's very difficult to progress from there, because this is where we talk about, so-called specialize. We just need to specialize. A regular clinic can become a specialized clinic if we start identifying and diagnosing these problems. See, any situation, once you identify, once you diagnose, treatment becomes a breeze. It is, that is, after that everything falls into place. Okay, this is the block, this is what it is, this ulcer is caused because of repetitive trauma. It's not healing because there's a bone protruding out there, or the pressure is uneven, and that's why it is there. And then after that, treating it becomes easy. We have to remove the instigating factor, probably the repeat trauma, etc. Again, most of these problems are repetitive, in the sense it can be a long standing problem. So it is just not that you treat one wound, especially in the foot. You treat one callosity wound which is happening on one side of the foot, and then just that heals and your job is not done. Because most of these, once the arch, especially the foot, the arch gets tilted, then the pressure shifts somewhere else, and we have to identify that and find long term solutions. So that is also for part of as physicians, preventing the disease and finding long term solutions is very, very important. And of course, preventing the problem. I think this is something which in our clinic at Ramaya Advanced Wound Care Clinic, what we do is we in fact, I always tell, we have the maximum space allotted for diagnosing and preventing diagnostic area, where we stress upon patients on preventing, diagnosing, preventing, educating them what are the possible complications, and identifying these patients. So we have a very thorough diagnostic approach and methodology in trying to educate these people and prevent these problems. So I think when we say specialized clinic, we have to look at these as problems. We have to identify, know the plausible problem, diagnose, treatment. Yes, in all these, the treatment is the most easiest part of the problem, which everybody stresses upon. But I think the rest of it is very, very important for us to understand. Excuse me. The long term solution and prevention of the problem is also very, very important when we look at these clinics. Just to give you an idea, when we talk about diagnosis, this is again pictures from our clinic. This is the diagnostic lab, that's the emed, that's the ABI room. You need sufficient space and area. You need to examine patients, because most of them are on wheelchairs, or not really comfortable. So you need to have adequate space. In terms of diagnosis, start with a simple ankle brachial index, thermal meter, neurosensitive analyzers, etc. These are basics. Like I said, we are talking about advanced clinic. If you're looking at basic clinic, you can just do an ankle brachial index, which is good enough to look at arterial insufficiency. Of course, when we talk about other wounds, we will need neuropathic assessment, etc. Here we have the pedography, which checks the pressures in the foot, and the transcutaneous oxygen meter, and neuropathy analyzer to try and identify polyneuropathy, etc. So these are the basics, which basics to probably moderate wound clinic should have. This again is very, very important if we are looking at the foot. This is a foot scanner which identifies areas, potential pressure areas in the foot, and yet it can tell you where the patient is putting too much pressure, how his gait is it causing any problem. Again, these are very, very important when we look at wounds, because not all wounds are due to infection, not all wounds are due to vascular insufficiency. A lot of time, even simple pressure shifts can cause wounds, and it's very, very important to know this. That's why I said you need to know the problem, and then you can identify the problem. This is very, very important, because we see a lot of patients with everything being okay, but there's a shift in pressure. They probably have a low arch or a high arch, and that causes shifting pressure. And as they age, especially again with diabetes, they lose the foot arch, and that leads to unstable arches and probably compression at different, pressures at different areas. So this is a foot scan which you have. And of course, in terms of treatment, customizing footwear makes a hell a lot of difference. Again, footwear has got, a lot of people, when they look at diabetic foot and or even pressure ulcers, they just talk about, MCR footwear or soft cushion footwear, etc. But that's not enough. When there is shift in pressure, it's ideally we need to customize. You can see this sole of the foot. It the system analyzes exactly where the pressure points are, and then correct it gives elevations where it is needed and shifts the pressure. So it's just not what it looks outside. It's very, very important what is on the sole of the footwear. That is what really helps, in shifting weight. So customized diabetic footwear is one of the components in managing these patients. Again, like I said, even in prevention of diabetic ulcers, even Charcot's foot, etc., a good footwear makes a lot of difference, takes it a long way, possibly some, most of the times pushes the inevitable to the maximum extent. And again, post intervention also, even if you simply remove a toe or part of the feet is debrided, you need to shift, because he's not going to put bare weight on that area, and automatically he shifts, his gait and foot pressure to an opposite side, and eventually that area takes the burden, and that can cause problems. So it's very important to sensitize these people about footwear, and that's again which goes a long way in taking care of these patients. Coming to the treatment room, of course, it's very, very good to have a podiatry chair. This is again from our clinic. This is a podiatry chair which has limbs which are separate and which height adjustable. Patient is pretty much comfortable. The idea of this is you get a 360 view of the patient's feet or ulcer area, because it is very, very important to examine it in complete 360 to look exactly what is happening around. So, and these are, collapsible, single limb collapsible. You can elevate one, depress one. So, good podiatric chair, adequate space. Again, very important to examine the patient sitting and look at the sole of the feet, because lot of time, when we are examining patients on sitting and he's resting his sole on the ground, we fail to see fail to see the sole. It's very important he's elevated, look down right perpendicular into the sole and see what is happening. A good light definitely makes, you see we have adequate daylight. Along with that, we have focus lights which gives us a better picture. So this is just a setup to let you know what happens. Having said that, in terms of PVD, arterial management, diagnostic, etc., what is next happening in terms of wound management? I spoke about arterial insufficiency, venous insufficiency, interventions for that, and diagnostic methodology in terms of a clinic. That's very, very important. I think, when we have a good diagnosis, we have a good people trained, a simple nurse who's been with you for some time, trains into it, is better understandable. In our clinic, some of our nurses are much more educated in food management than we are, because they are more sensitized and they're more, their work involves routinely food management, and they do wonderful jobs. Even in terms of diagnosis, managing these patients, most of the time I rely on their judgment to take necessary action. And experience teaches them, and it is better to listen. And it makes a lot of difference when you have people who are educated, who are into specific wound care management and chronic wound healing management. So it does make a difference. So apart from people, personal vascular insufficiency, diagnostic aspect, again, diagnosis, you need to know what you're looking for. You can't just get an ABI and don't know how to read it. And a lot of times ABI, I know when I talk about ankle brachial index, which is just to know your arterial insufficiency, a lot of time it is done. I see that unfortunately it is not read well, and it is in diabetics. A lot of times you have, false, gives you a report which apparently looks normal but is not normal. So I think that's why I said you need to identify the problem. You need to know about the problem. So diagnostics does not stop just by doing a test, because you have to clinically correlate that finding to what happens or what is happening to the patient, because each patient, we all know, is different and each has to be treated accordingly. Now, coming to the other aspect of local wounds, specifically going into wound management, with growing, antibiotic, and most of these patients with chronic wounds have tried a lot of treatment. Apart from allopathy, we see patients with alternative medicine treatment, some of them with home remedies, coffee powder in the wound, turmeric in the wound. I'm not saying they're bad or they're not good, but we have to be prepared for looking at what wounds are, or whether they're helping. One of the factors is how we do the dressings for the wound. How much are we looking at the wound as a wound? Is it exudative? Is it a dry wound? Does it require moisture? Does it require anything else to be added apart from, of course, when we are correcting the local and systemic causes? Is there anything else we should be looking at? So I think one of I will speak about dressings in a minute. One of the thing about, the growing thing which is happening is the biofilms. I think this is something which we are seeing very often, especially in chronic wounds, because these patients have gone through a lot of dressing. They've been to many clinics. They've already used, starting from local antibiotic cream to prostaglandin local applications to various other dressings, and this starts to form biofilms, and biofilms are pretty dangerous. I think this is one of the causes which we are seeing more and more, we are seeing, which becomes a challenge in trying to heal these wounds. So this is very, very important to keep in mind. So I just put this up so that we know what a biofilm is, and the presence of that definitely hampers wound healing. A lot of times it will be a good clean healing wound, and suddenly this develops and that traps the bacteria, and that leads, again, slowly the wound starts eating away. What was shrinking suddenly starts opening up, and you start getting larger wounds. So this is very much necessary to know and treat. So wound dressings today, I think there is varied options. I'm talking about dressings. I'm not talking about local applications. The various wound dressings which are available, starting from hydrofiber, ionic silver. There are different dressings with different benefits at different areas. What is important to know is what exactly are they doing, how exactly are they beneficial. And yes, we were all skeptical when, different dressings came into the picture, because we always thought, correct the systemic cause, correct the local cause, after that the wound will anyways heal. But unfortunately, or should I say, over time, people have realized that no, it is just not that. A lot of times you correct everything, still the wound does not heal, or the wound is taking much longer time to heal. So there are certain dressings probably which used, and which applied over the wound areas, helps hastening wound healing, and that is what we want. And just not the hastening, like I said, remodeling, probably giving better functionality, probably making it appear much cleaner. It makes a lot of difference when we look at these dressings. So it could just be, like I said, a hydrofiber foam dressing for moisture, etc. We could talk about dressings for different exudation. We talk about, aquacell, foam, cellulose dressing. We talk about alginate. We talk about powders, crystals dropped into the wound. There are various dressings which are available in the market, and we should know. I think what is important is biofilm, infection, exudate. All of these are potential threats for wound healing, and eventually, if they are controlled, healing happens. As long as it is exudative, healing is slow. When there is infection, obviously, apart, not only that it doesn't heal, it actually spreads. The other thing is the biofilm. I think with technologies like hydrofiber, silver coated dressings, it helps a lot in trying to control these wounds, decrease the biofilm, control the spread of infection, and of course, exudation is prevented. Simple dressings like hydrocolloid dressings are also found to be very helpful, especially in pressure areas, which is again one of the causes. Talk about trophic wound ulcers. These help, give enough protection to control the exudate, gives it cushioning, and also helps in keeping the wound dry for quite some time. So I think I will end with just talking about or summarizing what exactly services can be offered at a advanced wound care center. Like I said, I've just briefly gone through what are the possible options which are there. Again, necessarily nothing is so specialized. It can all be in managed with simple clinics with a little bit of eye to knowing the problem. So when we talk about advanced care center, we should offer enhanced screening and diagnosis. This is the most important aspect, and I will always stress on this. Treatment is always easy, but screening, diagnosing, and preventing becomes our responsibility. So treatment for ulceration, PVD, vascular disease, arterial and venous, definitely a possibility. Revascularization procedures, now it's minimal endovascular. We can do, approach any of these arteries endovascularly and plan for angioplasty, stenting, and improve the blood flow. Again, varicose veins, starting from open surgeries to laser ablation, radio frequency ablations, injections, sclerotherapy. There are various modalities with minimal interventions which can help reduce the venous insufficiency and help wound healing. Prevention of complications through periodic maintenance, care of corns, callus, nails. Take care of your nails. A good nail trimming helps a lot. Especially nail trimming, nail care makes a lot of difference. And this is very, very important as a specialized clinic in wound center to take care that the complications are prevented. Selective dressing materials, I think this is what I stressed in the last bit. You have to be clear with what you're using because you need to know what kind of dressings are available. Again, not all wounds require specialized care dressing, but you should have access to different dressing materials which helps in wound healing. Again, you should know where you can apply compression dressings like venous ulcers, where you have to take pressure off and then give cushioning dressings, etc. Treatment of severe and acute chronic infections, of course, infection and other management is as per any standard we look at. Offloading and footwear support services is also one of the requirements when we talk about a wound care center because this most of the time adds to preventing ulcers, preventing long-term care of these patients, and helps in taking care of these patients. So a good footwear, probably customized, is much better in these patients. We talked about even footwear itself is a big topic. We can talk about offloading footwear, different kind of rocking boots. We talk about footwear for Charcots, etc. This itself is big. And when we have a personal who she does only footwear management, so she's totally trained into that. So that itself is a big thing. So we need to know exactly what is happening. So well, I think wound care, like I said, start with arterial, identifying problem, arterial, vascular, venous. I mean, arterial venous problem is definitely treatable. Talk about diagnostic of these things. You just need few probably gadgets, so-called gadgets. But more than the gadgets, I think we need to know what the problems could be. If not with us, we need to send them to specialized clinic to assess, identify, diagnose, and then look at prevention of these diseases. I think with the growing elderly population in our country, with the growing diabetes, it's very, very important to stress upon prevention, screening, and diagnosing. So I think it's always a good idea to have at least as access to specialized clinic, if not that, to at least understand what we can do to help these patients. Thank you very much. I'm open for questions, comments, suggestions.
Thank you, sir. Thank you for a very good session. I'll just take some questions from the audience.
Yes, please.
So, a lot of what people are asking you have covered in your talk so far. However, we can still go through the questions as a recap. So an interesting question that I have come across is what I would ask you firstly. Somebody is asking the cost implications of a podiatric chair.
Well, Like I said, you know, the idea is to get a 360 view. So a podiatric chair helps it. It's more comfortable for the patient. He just lies down, and we can, you know, of course, what I showed you is totally electronic. It's controlled, but not necessarily. You could just have a regular chair, you know, just a simple dental chair, or
Right.
something where the foot can be, you know, up and down and see it. It's very important that there is adequate space around it. If you ask me the podiatric chair costs exactly, I'm really not aware, but I am told that the very good ones are now available, made locally. uh, but honestly, I can't put a figure to it, but it is available. But again, don't get bogged down by that. It's just that you need to get a full view.
We are good. Right. Um, so Vaidyanathan is asking, what has been your critical benefits uh, by moving into advanced wound dressing? What were the cost versus benefits? And has this reduced the number of dressings required for interventions versus gaze, which is routinely used? And are these specialized dressings available in India? So he's asked a lot of questions. I've just
There's a
put
lot
them
of
to.
questions. Okay. Yeah. The learning for me has been, like I said, I was also new to it. I still am understanding a lot of dressings. It's not that I've understood a lot of dressings. There are various dressings available in the market. If you ask me broadly, yes, they do make a difference. They do help in managing these wounds. Like I said, you know, wound healing is not just about the skin closing or just shrinking. We have to make sure it heals. The tissue is reformed in the right way so that it looks nice, the scarring is better, and you're able to put weight on it. And that is where I've seen a lot of these dressings come very effective in managing these patients. So it does help. As far as concerned with available in India, yes, very much available, very much. I think it is probably available in most of the cities, most of the 2 tier 3 tier cities. And but lot of them are in the market. It's as you use, like when we started, a lot of things we didn't have access to, but once when we started using regularly, we could make it available within our our pharmacy and close by hospital. So it is definitely available. I think I missed one more question in that. I'm not sure what was
Um,
that in that.
Cost versus benefits, and has this reduced the number of dressings required for
Yes,
intervention
yes,
versus the
yes,
routinely used case?
yes, definitely. Yeah, it looks, it is expensive. Yes, when you add, instead of just a gauze, you want to add one more into it. It does add to the cost. But if you look at the cost benefit ratio, it does make a difference. Like I said, it helps in shortening the healing process. More than that, even if it is not shortening, it heals it well, so that there is no, tissue loss or undermining of the edges or etc. So it gives a good clean heal. And a lot of times, some of these absorbent dressings, if you put it on, you don't need to change it for, regularly. If you have to change it alternate day, in this cases you can change it once in 2 days. And the other thing we also do is we give this to the patients and teach them how to dress themselves, so they do it at home. So we are also pretty comfortable when you say, okay, change a couple of dressings at home. That saves them the visit to the hospital, and they can share pictures and let us know how it is happening. There we have met, especially AG dressings, when we use and give it to the patients, we are more comfortable that probably the infection is much in control. So if you look at that broadly, that visit to the hospital, the trip to the hospital, instead of making 3 trips in a week, he comes once a week. Definitely, I think you can calculate the cost benefit there.
Right. And the quality of life is also affected.
Definitely, I think, see, it's a, I mean, sorry for using, it's a pain to keep coming to the clinic for the
Yes.
patient. If you ask him to come every day for dressing, it is, and especially if he needs assistance, he has to come with somebody. So two people's time is wasted. So if you can let go of them, or do, comfortable dressings, or put an additional dressing where you don't have to change it for a couple of days, it does help, and they're more compliant, I feel.
I think so. A lot of people are appreciating your presentation. They're saying it's excellent presentation and
Thank you.
really game.
Thank you.
Dr. Sunil is asking how common is recurrence of lesion after endovascular interventions in foot arteries?
How common is the
Recurrence of lesions.
lesions in the foot arteries? Yes, it is quite common. Uh, I'm presuming he must be a surgeon because this is usually comes from
Yes.
there. It is common. See, vascular, when we talk about angioplasties and others, a lot of these lesions come back or they reocclude. But the important thing is it helps the wound heal. It tides over the current problem. Now there is an ulcer or a gangrene, and then we restore the blood flow. It improves it. It gives it remains open. Probably the wound heals, and after that the lesion may come back, and or a new lesion may come because it's a progressive disease. You see, arterial diseases are progressive, so eventually they may reocclude. But the fact is, if the wound is healed, and that's why I said preventive care makes very important, so that the patient doesn't come back.
Right. Somebody's asking, in your clinical experience, what would you recommend as the best dressing for heel wounds, and would you recommend any special ointments?
I mean, very difficult to generalize and say all heel wounds require this. Like I said, we have to see whether it's a dry wound, it's a trophic wound, is it exudating. So unless that is taken care of, we have to be clear. And but I would definitely warn whoever is asking here. Heel wounds are very notorious. They are the most difficult areas to heal, and for us, a heel wound is a red flag. The moment there is a heel wound, we have to assess it thoroughly, because if the disease progresses, the infection spreads into the heel, it's a potential loss of leg. Because the moment it spreads proximally, the most weight bearing area of the foot is gone, and even it leads into an amputation. So like I said, it's a red flag when the heel is involved. So don't take heel wounds very lightly. As far as ointments and others are concerned, I'm clinically, I'll talk for myself. I'm very skeptical about ointments and other things in wound management. Yes, maybe in a couple of areas, but heel areas, if it is a pressure sore, I think a good pressure of dressing, hydrofiber dressing, etc., can make a lot of difference.
Right. Thank you. Um, I'll take a couple of more questions before we close for the day. So Dr. Yashwant is asking, are there any interventions for Berger's disease? Is it Berger's or Burgers?
Burgers. Yeah, it's both are fine. There are interventions. Well, see, Burgess is a very disease which is into the smaller arteries and very difficult to treat. But yes, we have done angioplasties. Difficult. We have done bypasses in these patients. I would just like to share here, and since Yashwant has asked, we have been doing trials on stem cell, and especially this, we have been working on stem cells in the last 20 years, and it is now commercially available. After 20 years of research, stem cell is a wonderful option in these patients. So it is going to be available in the market soon, or it is probably available in India. And this has shown wonderful results, and especially in Burgess disease, because they're most of the time they're not reconstructible. But having said that, if there is an artery, we can give it a go to try and open these arteries.
Right. Uh, Dr. Nirmal is asking about role of dilantin sodium powder dressings in chronic wound healing.
I'm not. I'm honestly, I'm not well versed in it. I've heard of it being used, but I really don't know. I don't want to say anything which I'm not really much aware of.
Right. And so this would be the last question, or maybe the second last question. Dr. Manish is asking, how can we assess the adequacy of blood supply in the wound and
Yes.
management of lower limb wound with skin loss?
Yes. Assessment of wound, I know you can just start with simple palpation of the pulses. You feel for the pulse, the peripheral pulses, and the pulses there, obviously, there is good flow. Even if two of the arteries, if you're looking at the feet, the posterior tibial or dorsalis pedis, just palpate for it. If it is there, it's more or less sure that the blood flow is good. Next is what we do, the ankle brachial index. So you just check the pressure in the upper arm and lower arm and calculate, and then you get a fair idea of what pressure of flow is there. Beyond that is one of the thing equipment I showed is the transcutaneous oximetry. You can do that to know how much oxygen saturation is coming down, or is that gives us an idea of blood flow. So that is as far as the wound is concerned. Of course, clinically, you scrape the wound, there is immediate good brisk bleeding that is suggestive of good, the no arterial ischemia. And I think clinically, as you see, you can see a pale wound, a raw white color looking wound, which is definitely ischemic. So yeah, I think there are methods. Yeah.
Right, sir. And since questions on diabetes never seem to cease, we will close with this question. Dr. Nikhil is asking, what is the best medicine for non-healing wounds in diabetic, and even if the patient is non-diabetic,
Best medicine, I mean,
for non-healing wounds in diabetic patients?
I mean, if we are talking about medicine, I would say, of course, we put all these patients on antiplatelets, very much needed antiplatelets. We use quite a bit of silistazole, but please be careful with silistazole. You need to know the renal and cardiac care, and of course, statins are used. So I think if you're talking about medicines, American Diabetic Association was, or I don't know, it was recently changed. They said any diabetic above 45 years old should be started on antiplatelets. So I think we thoroughly follow that. Any patients diabetic, even with a good pulse, the moment he shows first signs of ischemia, we put them on antiplatelets. Yes, statins, of course, and like I said, silistazole also we do use in these patients, but definitely antiplatelets.
Right, sir. Sir, so that would be all. Thank you so much for a great session. And I
Thank
hope
you.
we've been able to answer as many questions as possible. I think I've taken most of the questions. Uh, yes. So with that, I thank you so much.
Thank you. Thank you so much. Good night.